The first patient here was a 14-year-old that you responded for a seizure. I loved the description. Found patient lying in the fetal position on her right side, bouncing using whole body jerking movements. This is not a seizure. Patient is alert and oriented at X3, stating she cannot stop this bouncing jerking movement. And she self-reports that it was the 28th time that this has occurred in something like the past 3 or 4 months. Dad described the etiology as unknown, but being evaluated by a psychiatrist, neurologist, everybody at Children's Hospital. They think anxiety is her trigger. Concern that she was going to harm herself, so some Ativan was given by MAD device. From the documentation, it kind of looked like maybe there was some offering or suggestion of, hey, you know, it's okay if you want to refuse transport, but nonetheless, they decided they did want to be transported and were taken to Nationwide. So what does this sound like to you as this patient from this documentation?
Yeah, I can't answer this. I was on the run.
Psychological, I mean.
Okay. What would be the main concern?
We don't know why. We don't know what's. I don't know what's causing this.
Right.
So I mean, that's my main concern.
Yeah.
It's happened 28 times. And the parents are concerned. I don't know what's going on. I can't give you an answer. So,
Yeah.
so that's my big concern.
Yeah, so it sounds psychological, but maybe it is some sort of strange seizure, strange neuro disorder that we don't know and that everybody's having a hard time finding out. Who knows what's going on? So, to me, it sounds like a pseudo seizure, or the now preferred term that's absolutely amazing, psychogenic non-epileptic spells, penis.
Penis.
And referred to purely as penis. Versus, is this some sort of epileptic seizure? Is this some complex partial seizure that she's having? And so, just kind of wanted to go over, is that what you guys thought too? That
Yeah, her dad basically called it a pseudo seizure. The other problem we had on the scene is Dad has Asperger's, and so he was really almost non-communicative to us. But he told us a little bit. We learned more from the school counselors than we did from the dad.
Dad was saying, I don't want to take her.
Yeah, he didn't
But
want.
the school said, you need to take her. Mom would want her to transport her.
Yeah, Mom usually deals with her, not Dad, and Mom was in Marysville, so we.
So, acutely, when you're dealing with somebody that you think has a pseudo seizure, the goal is to make sure it's not a seizure. Because this isn't something that, you know, you diagnose in the field pre-hospital. This isn't something we diagnose in the ED in somebody newly. We are concerned for seizures, and so we work them up for seizures and go from there. Then they get admitted to a epilepsy monitoring unit, and these are observed with an EEG on, and that's when you know that it's a non-epileptic, psychogenic non-epileptic spell. So you guys know kind of some of the differentiating features between pseudo-seizures and epileptic seizures?
Well, one that was very obvious with her was she was very communicative.
Right.
And the movements was still going. It wasn't like she was full-blown grand mal and, you know, non-communicative. So.
And it even sounds like she was not having like a partial seizure with repetitive movements with one extremity or something like that.
Carry on a perfectly normal conversation with her.
Yeah.
Yeah, as her body was flipping all over the place.
Yeah.
So.
A lot of pseudo-seizures are more tonic-clonic in appearance. Typically, the patient will have their eyes clenched shut, which, as you know, you don't often actually see in epileptic seizures. There's often a lot of head shaking instead of head nodding, which doesn't make sense because with epileptic seizures, there's symmetrical muscle spasm, so you can't shake your head with an epileptic seizure. With psychogenic spells, they often will, as they kind of advance along, bite the tip of their tongue, but not like a seizure bite of the tongue where there's a massive bite, and often in the side of the tongue or the cheek, because those bites typically happen when the patient's on their side and something falling into the side, not just a small bite on the tip of the tongue. Things like soiling themselves actually becomes less reliable the more episodes a patient has. However, it's less frequent for a patient to have a bowel movement than to urinate on themselves with a psychogenic spell. So
All respiratory, right?
they will often hold their breath, but not become hypoxic or have increase in tidal CO2 or anything like that because they're just breathful. And
I have a question.
Yeah.
Can the activity be localized to, we have a girl that we've run on several times, and she has respiratory distress. She feels like her throat's closing up.
yeah, one that seems to have maybe vocal cord dysfunction or
Right.
Anxiety component of it. I think that's usually thought of as a separate thing, but both are considered more of like somatoform disorders by psychiatrists. So along the same spectrum, but typically considered fairly different. People have different methods for trying to stop a psychogenic spell. Some people use like little ammonia capsules. Some people shoot a saline syringe in the face and see if the person flinches. A common one is holding the hand over the head and dropping it and seeing if it'll hit them in the head. The favorite one that I've been told is to take like a 6-inch cotton-tipped applicator and insert it in through the nose, and that will halt pretty much all non-epileptic seizures. Here it's quite uncomfortable.
With the
Diagnostic tool.
This one gets with the
Nasal pharyngeal airway.
psychogenic seizure.
Well, you want to make sure they oxygenate. Gotta get that IP in.
With the psychogenic seizure, is it could there be causes that the patient is not necessarily in control of, like
Yeah,
they're
so
not choosing?
So
it's not a display.
it is
of
believed
something.
that this
Yeah.
is not a purposeful thing. This is a disease process. This is along a spectrum of psychiatric and neurologic disease. That's why we don't use the term pseudo-seizure anymore, because that makes patients feel that you're accusing them of faking something, and it's not approached that this is something the patient is choosing to do.
When we got this girl to Children's, they almost knew her by, a lot of them knew her by first name. She'd been there
Yeah.
quite a number of times. And it was actually either realistic or also sad to see, because a lot of the people that saw her immediately dismissed her instead of, you know, does she truly have some type of psychiatric disorder that they're still treating? So
Yeah. So, I mean, 28 times in 3 months, yes, she has something. You don't make this up. Like, you've got something going on. But luckily, it's not going to be life-threatening. So, acutely differentiating from seizures is really the main goal. There's no specific medication or anything like that. Chronically, it's just psychotherapy is the cognitive behavioral therapy is the most effective thing in dealing with these.
You know, the other thing is sometimes they have both. They have seizure disorder. And the other thing is that sometimes they've had a horrible trauma in the past. Some horrible experience, rape, physical, sexual trauma that they're trying to work through. And this is kind of like a conversion disorder. But, so I think they need a little more sympathy than just say, hey, you're faking this and bugging me. You know, they really have had sometimes a very horrible event in their lives.
Right.
So to your point, Mike, you know, they do need treatment, and sometimes you can't tell, so they do need to be in the unit.
So what is your recommended treatment in the field?
In the field?
Yeah.
Well, I think you can say, hey, you're faking it. Look, I really don't want to be here. You know, I guess we'll just take you in. Well, or you can say, no. I mean, this person really has a problem, a difficult problem. We need to give them support and help.
Yeah, so are you saying that you give them something to sedate them to calm them down?
Well, I don't think it would hurt. I don't think it hurts
Okay.
particularly. But I just think they need to be transported and evaluated.
this girl we've transported a couple times, and sometimes she's gotten a sedative and sometimes not. The reason we did it this time was she just didn't seem to control her head, and it was just bouncing off the floor.
Yeah, I thought your documentation was very appropriate, that you were concerned, despite the fact that this did not look like a seizure, for her safety because of the movements. So I think that in that case, when you're concerned like that, that would be the appropriate time to give a benzo.
Just gave her some Ativan.
Yeah.
Through the mat. And it did seem to slow, didn't completely stop her head, but it slowed it down.
Did you just give her 4?
Is that the med-
I only gave her 2. Actually. Didn't give
Is
her-
that the medication of choice?
I think that's
Yeah.
a great
That's
option. That's what I would use.
Okay.
And if there's not a safety concern, and this is well documented and they're responding, and it does not look in any way, shape, or form like a seizure, then I think you can transport without medicating. But
And Dr. Ron,
Yes.
what you said is a trauma in the past or a stressful situation. How about when, like, her dad was almost adamant about not going?
Yeah.
Yeah, he didn't want her to
That's a
go.
stressful situation. How adamant should we be with the parents when they're saying, no, I don't want my child to go? There's nothing they can do at the ER.
Oh, she's really got a problem, we can't just leave it like this. She needs treatment. needs to
It was a
get-
frustrating situation,
Yeah.
I'm sure, for him, because they'd been to the ER many times,
Yeah.
spent 12, 14 hours in the ER, and then hers tend to stop after about 40 to 50 minutes, but then they run her through the whole evaluation again.
yeah.
But he didn't really want her to go, but the counselors and us, we finally convinced him, basically using his wife, saying she would want her to go.
Yeah, it's a little different. She was conversing and awake, and it's not exactly like their eyes are closed and teeth are clenched. So it's a little different, maybe.
All right. Next case was a 72-year-old possible heart attack on the bike trail. So this was a 72-year-old woman that was cycling with some friends and was ahead of those friends. And when they came upon her, she was kind of standing, hunched over her bicycle. Initially complaining of chest pain, noted to have some slurred speech, some nausea, and some weakness of her left arm. She was found to be an AFib. Once the weakness and the slurred speech were noted, a stroke alert was called, and she was taken to Riverside.